Right. Hello, everyone. My name is Saloni, and my colleague here, Devika. We're going to talk about the A2E assessment station that you see in OSCEs. We're going to go through all the steps, and please feel free to ask any questions and put them in the chat box. So the aim of the session is all the steps of the A2E assessment, and then we have two scenarios that are prepared, and we'll love it if you guys interact with us, ask us questions, and pop in all your answers in the chat box. So as you know it, A2E assessment is a quick assessment of different systems of the body. So starting with the airways, then you go to breathing. So you're checking the chest, lungs, circulation, so function of the heart, your pulses, disability. So a quick examination of how alert the patient is and the neurological function. And exposure is adding on to your examination so far. So anything else that you'd like to know about the patient. A general rule for A2E assessment is you want to assess these systems, recognize if there are any abnormalities, and then treat them.
Right. So some general tips for performing the A2E examination is ask for senior help. So if you've seen a patient, you've done an A2E assessment, don't hesitate to ask your seniors for help. If you're not confident in performing it, ask for help early on. And when you do, summarize it using the SBAR method. Don't be shy to use your team. If you're leading this A2E assessment, make sure if you have nurses around you or other juniors, say, can I have some bloods? Can you do an APG to fasten the process? Treat problems as you encounter them. So if you are doing let's say you start with airway, you see a problem, treat it as soon as you can. See if your intervention has actually worked, and if it has, only then move forward. Review investigation results as soon as they're available. So for some things like, let's say, an arterial blood gas or chest x-rays, those results might come faster than your bloods. So whenever you get the results, see if there's any acute problem and treat it. Keep assessing. So you finished an A2E assessment, the patient's stable. Let's say you're waiting a review from a senior. If you finished E, then go back to A and keep assessing and seeing if there's anything else that you can do for this patient. Remember, if it's an inpatient, always check the prescription chart, because, for example, the patient's unconscious, it can give you a lot of information like the allergies, what they're on, and possibly if there's an error in prescribing that could have led to an acute deterioration in their health. And once everything is sorted out, the patient's stable, make sure you document everything that has happened. So moving on to airway, the first thing you want to see is, can the patient talk? If the patient can talk, that would mean that their airway is patent, and then you can move on to breathing. There's nothing else to do. However, if the patient can't talk, there are two things that you'd want to do. So the first thing is you want to inspect them. Look at the patient, see, are there any signs of any airway compromise? So if there's any cyanosis, any use of the accessory muscles. Also see if you can hear any sounds such as a stridor or any gurgling or any snoring that could potentially indicate maybe there's an obstruction going on. Then you want to look inside the mouth very carefully. You want to see if there's anything obstructing, such as any thick secretions or any foreign bodies. Considering that the patient's not able to talk, you think the airway is compromised, even if you're in doubt that the airway is compromised, it's always better to intervene and do an airway maneuver to be safe. So in terms of intervention, the most commonly the first step you're going to take would be the held tilt chin lift maneuver. And that's just basically you place one hand on the patient's forehead, another one on their chin, and then gently extend the neck upwards. And then assess the patient. If you feel this has helped, the airway is secure, you can then move on to breathing. However, if you feel that you're still in doubt, the patient's airway is not working, well, you can move on to the second maneuver, which is a jaw thrust. And that would basically be, you place both your ankles on either side of the patient's, behind the patient's mandible, and you put some upward force such that you push the jaw slightly outwards. So these are your basic maneuvers. If you've done both of them and you feel like the airway is still not improving, you can go on to putting in some basic airways. So this would be an oropharyngeal Guedel airway. And then you have the choice of even putting in a nasopharyngeal airway. Can you guys think of any reason where we wouldn't insert a nasopharyngeal airway? You can just pop it in the chat box. Okay, so yeah, so a base of skull fracture. So if the patient has a fracture of the base of the skull, you don't want to insert a nasopharyngeal airway. That's because there's a small risk, but nevertheless a risk that it can possibly go into the cranial vault. So in that case, you wouldn't do a nasopharyngeal airway. However, if the patient is conscious and they don't have a basal skull fracture, NPAs are better tolerated. If the patient's unconscious, then a Guedel airway would be a better option. But this is not like a strict rule. You just have to assess every patient on their own. And moving on to breathing. So there are 4 main things you're going to be doing, which is observation, examination, investigation, and interventions as required. So when you're observation, you're going to observe the basic observations. In case of breathing, it's going to be focused on the oxygen saturations and the respiratory rates. Be aware that in COPD patients, some of them might be at high risk of CO2 retention. In those cases, 88 to 92% is normal. Then you want to do an examination, and it's going to be basically a respiratory examination, but a smaller condensed version of it. And that's because the reason you're performing an A2E assessment is to rule out any acute life-threatening emergencies. So because of that, you want to perform a condensed examination to quickly recognize problems and treat them. Investigations, things you can order that would be relevant in the breathing section would be an ABG if it's hypoxic, or a chest x-ray. And in terms of interventions, so those can be quite broad. You can give oxygen, nebulizers, steroids, antibiotics. It all depends on what the patient presents with and how you think is best to treat them. So if you, let's say a 72-year-old male comes in with sudden onset shortness of breath, he is hypoxic with oxygen sats of 92%, how much oxygen will you start him on? If you just pop the letter of the option you think is correct in the chat box. Yeah, so E, 15 liters. If anyone who comes in with shortness of breath, and if you don't know anything about them, always start them on 15 liters via a non-rebreathe mask. Let's say this patient came in, they have COPD, and they've come in with 92%. So yeah, there is a chance that they could be the group where 88 to 92 is normal, but you won't know that until you take an arterial blood gas and test it. So start them on 15 liters, do a quick ABG and test it. And then accordingly, you can change the oxygen supply.
Right, so moving on to circulation, these are the things you want to do. Again, it's a condensed version of your full cardiovascular examination. So you start with the pulse. You want to check what the heart rate is. Are they tachycardic? Are they bradycardic? If it's regular or irregular. And then move on to listen for heart sounds. So typically it's S1, S2, and no other sounds. But if there are any murmurs, try to recognize them because they might be contributing to what your patient is presenting with. Then check if their capillary refill time is less than 2 seconds, which is normal. Move on to blood pressure. So that's your normal range for your blood pressure. And can you think of any bloods that you would want to order in a patient? Just basic bloods that you'd want to know. Let's say the blood pressure is low, or they're coming with dizziness. Yes, so full blood count is one of the main ones that you want to order. And these are all good ones. So group and save, you'd add on to it if you think there's a reason for them to go into surgery or if they're bleeding. So those are some of the basic bloods you'd order. So full blood count is almost in every patient you'd order those, and the others you do it case by case depending on what they present with. You want to order an ECG, and on the ECG you want to check rate, rhythm, if there's any ST elevation, if the PR segment is there, if the P wave is even present. What about the T waves? Is it tall tented? Does it indicate any types of abnormalities with electrolytes, etc.? Then let's say you find out that the patient's blood pressure is low. How would you manage that? Anything, if you guys have any ideas, you can pop them in the chat box. Yes, so you would want to know the cause of the shock, that's right. And in the meantime, you want to start them on IV fluids, that's right as well. So first of all, in an OSCE examination, you want to say that I would like to insert 2 large bore cannulas. So this is usually 14 gauge or 16 gauge, 14 gauge or 20 gauge cannulas, 16 gauge cannulas, sorry. So the gray ones or the orange ones. Then you want to give them a fluid challenge. So that's usually 500 ml of 0.9% NaCl, which is normal saline. And you want to give it start, or you can say over 10 minutes. So this is typically what they expect you to say. And this is typically what you'd give to a patient if their blood pressure is low. And finally, you want to find out the cause of the shock. So consider sepsis pathway. Goes along with everything else. So do they have a raised temperature? Are you suspecting an infection? And other causes of shock. Can anybody else name any other causes of shock? PE, so yeah, a lot of things can cause it, but shock, we usually classify it as anaphylactic or hypovolemic or cardiogenic. So yes, you would want to find out what's causing the shock. So moving on to disability, the quickest thing to do is AVPU. So when you talk to the patient, are they talking back at you? Are they alert as you examine them? Or are they're sort of in and out of it, but they're still talking to you? Pain is when you're trying to talk to the patient, there's no response, but when you squeeze their trapezius or you squeeze about their eyebrow, that's when they respond. So that's pain. Or is the patient completely unconscious? So usually if the patient only responds to pain, that's a GCS roughly of 8, and you want to consider bleeping ICU because they might need airway support. And I'll talk about the GCS in the next slide. When you check the eyes, you want to check if the pupils are equal on both sides, if they're reactive to light, and if they're accommodating. Then you always check blood glucose, make sure that it's in the normal range, and check the patient's temperature. Let's say the patient has hypothermia. What would you like to prescribe the patient? Any other ideas? You can prescribe a lot of things, but the first most basic thing you want to prescribe is paracetamol because it's an antipyretic. So it will just bring the temperature down. It's the quickest one to do. And then if that doesn't work, you can build on and prescribe other things. So D stands for disability, and also don't ever forget glucose. It's one of the most essential things you need to check. Let's say you check glucose and the patient is hypoglycemic. What are some of the options that you have to correct the hypoglycemia? Can you give the patient anything? So it depends on how conscious the patient is. So if they're talking to you, their responses, they're able to swallow food, you can give them some oral drinks. So glucosate is the commonest thing. You can give them quick orange juice. Let's say they are conscious, but they're not cooperating with you. You can give a gel in their mouth, which is called glucogel. If they're unconscious, then you need to consider either IM glucagon or IV glucose, which is dextrose. If the patient is hyperglycemic, on the other hand, you want to find the cause. So you start with checking the urine for ketones and also do an ABG because you want to consider if it is diabetic ketoacidosis. And if it is the case, then you want to start IV fluids. So Glasgow Chroma scale. this is how you measure it. There's more about it in the next presentation, which is on neurology station. So here you want to check if the patient is talking to you. If when you go to them, they look at you, or do their eyes is closed, but they're still talking to you. They know you're around, or do they only respond to pain? So like I said before, you do a trapezius squeeze or a supraorbital pressure, or just squeeze there, and they would respond to the pain. Verbal. So when you talk to the patient, you ask them questions. Do they know where they are, what time of the day it is, who you are? Or do they seem a bit confused? Are they only they're saying some words that might not be in line with what you're asking them? Or is it just a few sounds you don't understand? It's not really anything. And for motor, so when you do the trapezius squeeze, does the patient try to move your hand away? The patient knows the pain is there. Or is there an attempt to move the hand, but they don't reach completely there? And then you have your abnormal flexion and extension. So when you squeeze, do the patients just bring their hand together? So that's called abnormal flexion. And extension is they have no response. They're sort of drawing away from the pain, but they can't localize to the pain there. So exposure, finally, you want to check some of these things. So abdominal examination is one of the common things that you perform. It's standard to perform in all patients. You want to know if the abdomen is soft, there's no pain, and the bowel sounds are present. And then additional examination would depend on the scenario. Do you want to check the calves? Do you suspect a DVT, a PE? So you want to find the source there. You can take a history from the patient if they're responsive, and also collateral history. Were they brought in by an ambulance? If they were, then you can ask the ambulance crew what they know so far about the patient, or the family who is with them, or their friends, or whoever is there with them, accompanying them. If the patient is in any pain, then you want to take a pain history, find out where the pain is. And finally, you can look at the patient's notes. It can be electronic. They may have it with them. They could have been an inpatient before this. So have a glance at their notes, what medications they're on, and also their news chart. Is it getting worse since they've come in? Is it the same if they've been here for a long time? And this is what you would typically see when in an A&E setting when they do an ABCD exam. So they'd say the patient is alert and oriented to the place. So you can either write it as that, or you can say the whole thing. You say airway is patent if the patient is speaking to you, they have no breathing problems. You listen to the chest, it's clear, the lung sounds are equal on both sides. You want to write down your observations as well. And then you want to write your heart rate, blood pressure, everything that we've discussed. You just quickly jot it down. This is how you typically see abdomen. So you draw an abdomen, an arrow going through anything means it's clear, you don't find any abnormalities. And if you've examined the calf, then you can comment on that as well. So moving on to scenarios, I'd love it if you guys can pop some ideas in the chat box. What would you like to do? If you see a patient, he's 70 years old and he's presenting with shortness of breath, his COVID test is negative. So the first thing is you try to talk to the patient, and he tells you that he's been feeling short of breath when he's sitting down for about 3 days now. He's bringing up a cough, but there's no blood in it. Is there anything else you want to ask the patient before you examine him? Yeah, that's good. If the patient is in pain, the patient says, no, I don't have pain anywhere. Yes, color of the sputum. So it's pink, frothy sputum. You have a look in his bowl. It is pink and frothy. Good. Any medical conditions? So he tells you that, yeah, he has high blood pressure. About a year ago, he had a heart attack, and he also has heart failure. So he also tells you that he takes some medications. So that is a list of all the medications that he's on. And one of the most important things that you want to ask this patient is if he has any allergies before you prescribe anything at all. Usually in A&E, you might not have any previous notes. So make sure that you know that the patient is not allergic to anything before you start prescribing any antibiotics or any other medications. So moving on, do you think the patient's airway is patent? Yes. Why do we think it is patent? Correct. So the history was taken from the patient. So the patient is talking to you. So we know that the airway is patent. When you examine him, you don't hear any additional sounds. So brilliant. There's nothing in their mouth. They don't have any problems with that. Moving on, when you examine them, their respiratory rate is a bit high. Their oxygen saturation is low. And when you listen to the chest, you hear crackles on both sides in the lung bases. So what would you like to do now? Good, chest x-ray is an option, but in the meantime, before that, the patient is struggling to breathe. What would you like to give? Correct, you want to give some oxygen. And you can do an ABG just before the patient is started on oxygen, or you can do the ABG once the patient is on oxygen. In this case, you'll give high flow oxygen, 15 liters, like we discussed before, through a non-rebreather mask, and monitor the oxygen saturation throughout. And you have ordered a chest x-ray. It will take some time to come back. So in the meantime, you move on to circulation. So you find out the heart rate is slightly raised. It is raised 127, but regular. Blood pressure is normal. You don't hear any murmurs, but the JVP is elevated. So you order an ECG. What do you see here? That's all right. ECGs are not my strongest pursuit either, but here we start logically. So here, can we see that it's regular? Yes. And when you do 300 divided by the two big boxes, about 150. So the patient is tachycardic. It doesn't exactly match this scenario, but I found the best ECG I could for this. So the patient is tachycardic. You can see their P waves. There's no ST elevation, and we don't see any bundle branch blocks if you want to check that as well. So this would be a sinus tachycardia ECG. There are no other abnormalities, just sinus tachycardia. So you move on, and you want to give the patient 2 large bore cannulas. Their blood pressure is fine, so no IV fluids, but do you want to get any bloods from them? Yeah, so you want to check FBC. Why? What would you like to find out from the FBC? Anemia is an option, yeah. So you're checking the hemoglobin. What else? So yeah, you will also check white cell count to find out if there's an underlying infection for this patient, and Usinase, and also troponin, because they do, even though their ECG is normal, you want to rule out any other causes that might have caused this elevated JVP and the increased heart rate. So you want to rule out any new heart attacks because the patient has a history of a heart attack. You also want to order an echocardiogram to find out if the patient's heart failure is worse, if there are any valve problems, anything that might be contributing to this new presentation. So moving on to disability, the patient is alert, he's talking to you. The GCS, so it might be written as 15 out of 15, or you can also write it as E4, V5, M6. So all of it is normal, and the pupils are equal and reactive to light. Is there anything else you want to know in disability? Blood glucose, that's great. So blood glucose and also temperature. So his temperature is normal, his blood BM or blood glucose is normal as well. Right, so exposure, the abdomen is soft, non-tender, the bowel sounds are present. Is there anything else you want to check? So we know the patient has a history of heart failure. His JVP is elevated. So there's a degree of fluid retention somewhere. So where can you check to find out? if there are two things in a cardiovascular examination you do towards the end to check if they have signs of heart failure. Good, pitting edema in the legs. So you check the ankles. So when you check his ankles, he has bilateral pitting edema all the way through to his knees. And we've already discussed his sputum bowl has pink frothy sputum. So someone calls you, the results are back, all his bloods are normal, there's no anemia, there's no signs of infection, his U's and knees are all fine. And here you go, you have your chest x-ray back. What do you see? Is it normal? No, exactly. So yes, so there is some haziness or consolidation around both sides there. That's typically called a bat wing sign, which is seen in heart failure. So you can see that. So what is that a sign of? What do you suspect is going on in the lungs? What may have caused it? Pulmonary edema, that's right. So you know there's fluids in his lungs, in his legs, so all of these are pointing towards heart failure. And you get his echocardiogram back, and it says that his heart is enlarged and his ventricular ejection fraction is decreased, which we already knew because he has heart failure, so that was expected. So now you want to present your findings. So quickly summarize it as an S-bar. So we know that we have a 70-year-old male with shortness of breath and pink frothy sputum. He has a past medical history of heart failure. When you do his new score, it's 6. He has bilateral crackles and pitting edema in his legs. And his bloods are normal. Chest X-ray is showing pulmonary edema. And you've started him on high flow oxygen. What is your working diagnosis? Yes, so this is acute exacerbation of heart failure. He has congestive heart failure. How do you manage that? The patient is still feeling a bit short of breath. It has improved. His saturations are coming up, but he's still feeling a bit short of breath. Can you do anything to reduce this edema in his lungs and his legs? Can you give him something? Yes, diuretics. Does anybody know what kind of diuretics we can give? Yes, so you want to start them on loop diuretics, on IV furosemide, about 40 milligrams. And if their saturation is improving, you want to repeat the ABG as well to see if there are any changes to that. You want to start them on hourly observations. So on the news chart, when your score is above 5, you want to do observations every hour, and then present this finding to your senior, everything you've started them on with your S-bar, and discuss further management plan. I hope you found that interesting. I'm going to hand it over to Devika now.
Okay, guys, we're going to come to scenario 2, which is the last scenario. Here we have a 78-year-old male who's also come in with shortness of breath. POC negative, that's just the COVID test, so he's COVID negative. In terms of the initial history, the patient tells us that he's been breathless for 2 days out of 7. He's got associated chest tightness, and he's been using his blue inhaler about 15 times a day. In terms of his past history, he has got high blood pressure and he's got asthma. He is on the following medications. So he has a salbutamol inhaler, he's on Clenil, Montelukast, and amlodipine. And he's got no known drug allergies. So that's what NKDA stands for. The patient is talking to us, but he cannot complete a sentence without getting breathless. Do you guys think that airway is patent? You can just pop in a yes or a no. Yeah, so the airway is patent because the patient's talking to us. The fact that he can't complete a sentence without getting breathless will point us to a working diagnosis rather than pointing us to like an airway problem. Moving forward, we go to breathing. So what will you want to assess? What things are we looking for? What is Clenil? So Clenil is basically, it's an inhaler used in asthma. It's a combination of, basically a steroid inhaler, and it's the brand name. So quite often on wards, you would see that they write the brand names for inhalers because they vary a little bit. Yeah, so what will you assess? So you've got his oxygen saturations and respiratory rates. He is hypoxic and he is tachypnic. What else would you want to assess? Yeah, so after you've done the basic observations, you're going to be checking the respiratory system, so do an examination. The trachea central, in terms of his chest, he's got a bilateral wheeze, there are no crackles, his chest expansion is symmetrical, percussion, so NAD is no abnormality detected, so percussion is fine. And usually when you see it on a patient's notes, they're just going to draw two lungs and like write X where they feel they've heard a wheeze or any other sound. So in this case, it's a wheeze. Now that you've got his basic observations and you've got the examination results, what would your next steps be? What would you want to would you consider any investigations? Yeah, perfect. So we'll do an ABG. Is there anything else you want to, is there any other investigation? Perfect, yeah. So an ABG and chest x-ray, those are the two things you want to order in this case. You do an ABG, and ABGs are fantastic because the results come right then. And so that's what the ABG shows. What do you think this ABG shows? It's all right if you guys can have a guess, but if you don't want to, that's all right as well. But just have a read of the ABG and see. So if you look at it, you can see that the pH is low. Oh, perfect, yeah. So someone did say respiratory acidosis, that's correct. How we reach that conclusion is first you start with the pH. The pH is low, it's less than 7.35, so it's an acidosis. You can see that the patient is hypoxic. Move on to CO2. Is the CO2 high or low? So if the CO2 is high and the pH is low, that would point to respiratory acidosis. And then look at the bicarbonate. So in this case, it's within normal value. But if it wasn't, you would think, is there any metabolic compensation? So these are fine. So this patient has respiratory acidosis. The next question is, what type of a respiratory failure is this? So it is actually a type 2 respiratory failure. That's because in type 2, the patient will be hypercapnic, so increase in CO2 and hypoxic, which is the case here. In type 1 respiratory failure, they would only have a low oxygen, but their CO2 should be normal. Okay. An important thing is to consider is if you have a patient, let's say with asthma, and they have a normal CO2 level, you would be worried because that would mean that their body is getting tired and they possibly require ITU support. So if we're moving on to, we ordered the chest x-ray as well, and that's what the chest x-ray showed. Do you guys think this is a normal chest x-ray? So if we're just having a look at the chest x-ray, you could see that the trachea is fine, it's central. In terms of actually the lungs, looking at this side, you can't see any consolidation, any signs of infection, that's good air entry. On the other side as well, apart from this lesion here, it seems to, there is no other consolidation, there's no other sort of signs of infection that you can see. There's no cardiomegaly. You can see the hemidiaphragm's clear, no fluid on any side, so there's no pleural effusion. Yeah, and there's no air under this side, so you're not considering anything with the abdomen or perforation. So yeah, there's a lesion on the left side, but apart from that, the chest X-ray is fine. Considering everything, his history, you've done the A and the B. So what intervention would you start him on now? You guys can shout out any answers there is. So he is hypoxic. Yeah, nebulized bronchodilators, good. And for his hypoxia, what would you give? Oxygen, yeah. So now this is a bit more if you're more on like phase 2 in clinical years, but even if you're not, why don't you guys have a go? Which of the following would you initially start the patient on? So you got a patient who's breathless. He's using his inhaler 15 times a day. The ABG showing respiratory acidosis. Given what you're thinking, what would you want to start him on? Yeah, okay. So you got a couple of responses. The correct answer would be to start him on, the first thing you want to start is salbutamol 5 milligrams and nebulized with oxygen. So right now your working diagnosis is probably asthma because he's using his inhaler and he's got a history and he's got wheeze, which is consistent with that history. So 7.5 would be a bit too much. Usually start either 2.5 or 5. 5 is more commonly used. Ipratropium can be added, but first you want to start with salbutamol, prednisolone or hydrocortisone. So yes, you will also give them a steroid. Both are correct answers. The doses I gave were wrong, which is a bit tricky, so I apologize. But yeah, prednisolone, so the normal range for prednisolone would be 30 to 50 milligrams, and you give that orally. If they can't have any oral steroids, then you want to give them IV, and that's when you consider hydrocortisone. So as per your recommendations, the patient is started on salbutamol 5 milligram nebulized with oxygen, prednisolone, and ipratropium. But you've only reached B, so let's keep on moving on. So we go into circulation. We see that the heart rate on arrival was 120. That was his blood pressure. His capillary refill time is less than 2 seconds. Heart sounds, so 1 + 2 + 0, so it's normal. And you can't hear any murmurs. JVP is not elevated. Would you want to do any investigations or should we move on to D? What do you guys think? So let's focus on his basic observations. Is there anything on that which would make you think, let's do a basic investigation? Something that would be quick and easy to do in this gentleman. Yeah, it is slightly high, but it's not, wouldn't be too concerned about it. So because, well, he has a history of hypertension, he's on a medication, probably because he's unwell and he's also come into hospital, that could have raised his blood pressure slightly. But what about his heart rate? Considering that he's tachycardic, would you want to do any investigation? Yeah, that's it. So you want to do an ECG, just because he's tachycardic, which might be because he's feeling unwell, but you still want to do an ECG just to cover your bases. You do an ECG. And that is what you get. Any guesses on what the ECG shows? I promise you it's nothing complicated. Just if you look at the lower strip, which is lead 2, what do you guys see? Perfect, yeah, sinus tachycardia. That's literally all the ECG shows, which is in keeping with his basic observations. So at this point, I know it shows sinus tachycardia, but in this case, you're probably thinking it's more because he's feeling unwell because of, you know, the problems in his breathing, and that's what's contributing to his tachycardia. So you don't actually want to do anything else because you've pinpointed the cause and you're treating the cause. That should eventually help calm down the tachycardia. You move on to disability, and the patient's alert, his GCS is fine, his pupils are equal, reactive, accommodating, his blood glucose is fine, his temperature is fine. So there's nothing else to assess in this scenario, in this case, because the patient's fine in disability section. When you come to exposure, is there anything else you guys want to assess in this patient? Any other examinations, any other parts of the body, anything else you particularly want to look for? Okay. Yeah, an abdo exam. It's always good to do an abdo exam, even if the patient, let's say, comes in with chest pain or shortness of breath. It's not going to take you time, and if there's something else contributing to it, you can find out. So an abdo exam is good. The abdomen's soft, non-tender. He's got normal bowel sounds. That's usually how it's going to look like when they draw it on notes. The other thing you want to check is if there's any calf tenderness, any redness or swelling, thinking there's any DVT, potentially could there be a PE. That's always good to check in a patient with shortness of breath. It could possibly help you with the diagnosis, but in this case, it's fine. No rashes, always good to ask just to see if anything else is contributing. The rash could also potentially say, is it a DVT or is there something else going on? So you do all that. Next steps. So as we were talking, the diagnosis is an exacerbation of asthma. In terms of the management, yeah, once you've done an A to E, you feel like the patient's stable, go get a senior review. Tell them what you've done. Is there anything else you like? Treatment, we already started it in breathing. And once you finished your A to E, go back to A and see if actually everything you've put in place, has it helped, has it not? If it's not helped, what else can you do? In this case, the patient is responding well to the treatment. He's back to his heart rate's back to normal, his blood pressure's still okay, systolic, slightly high, but it's not concerning. His oxygen's coming back to 97% on oxygen. His respiratory rate's back in normal. His temperature was always fine. So in this case, you can say because you gave the right treatment, the patient responding, so your working diagnosis is correct. I did show you that chest x-ray. Do you guys think that the results of the chest x-ray, what you saw, requires any acute management? I can bring you back to the chest x-ray if you guys don't remember. Yep. So if you saw this chest x-ray in a patient, the patient's come in acutely unwell. We see this, would you do anything acutely to manage them? You guys can just hazard a yes or no answer if you like. No, yeah. So, I mean, there is a suspicious lesion here. You could possibly be thinking, is this a lung cancer? Is this any other thing? Yeah, it could be, it could not be, you can't confirm it. But in this case, you thought it was asthma, you gave the treatment and the patient responding. So that was his cause of feeling acutely unwell, not this lesion. You can't do nothing about it. You would want to refer them, tell the GP, and they'll do maybe do a 2-week wait rule and then refer them to get it sampled or tested. So you would want to tell someone about it, just not ignore it. But no, it's not relevant in an acute setting. The reason I put that in there is because often when you do see patients, especially if you're seeing them in an acute setting, you can find other problems that may not necessarily be contributing to the acutely unwell state. But as you guys rightly said, it's important to prioritize and see what you need to do next. Yeah, okay. And before we move on to questions, the other point I think we wanted to make was we gave shortness of breath in both cases, but one was a cardiovascular sort of a case and one was a respiratory. And our aim was someone with shortness of breath can come in with loads of things, so it's not restricted to one system. So you guys saw a taster of what it could be a cardiovascular resp. But other things it could be is, you know, they could have very severe anemia. It could be trauma. It could be something like hyperventilating, maybe due to anxiety or any metabolic abnormalities, overdoses. So just keep a broad mind, just keep your mind broad and then narrow it down with all your investigations. Do you guys have any
go on.
questions? No, that's it. Do you guys have any questions?
Just before you leave, could you guys please fill in the feedback form? Devika's going to put it in the chat box. We'd really appreciate it if we have some feedback. This is the first time we've done the A2E station and we're planning to do a few more throughout the next couple of weeks. So we'd love some feedback, how we can improve, if there's anything else you guys would like to see. And we're happy to take questions. I'm just going to stop the recording so you guys can unmute and ask questions if you want.